Welcome to the iconic talks Retina Vitreo Retinal disease session number 5, 6. So I welcome you all to this session with the chair Dr. Malika Goyal, myself Dr. Co-chair Dr. BNR Subudhi. Then I think Dr. Vibhuti Bhushan is, are you there? Please take your rest now. Yeah. Co-convener Dr. Veer Singh, are you there? And Dr. Piyush Banshal, yeah, he is on the dais. Yeah, so he will be the. You are moderator for all the papers, including yours. So please, you can start. Yeah.
So, very good morning. Thank you, Dr. Subudhi sir and Dr. Goyal ma'am. So, I'll be speaking about just a variety of surgical cases where what we do is ILM peeling post vitrectomy.
Not moving.
Yeah. So the first case scenario is the most common indication where we do ILM peeling. That is when we have macular holes, and as you can see over here, the most mostly followed technique over here is. Do I? One second. So as you can see over here is what is being done is a macular excess, that is the ILM is being peeled in a fashion similar to a capsular excess, that is in a circular fashion. And this one especially does when you have a comparatively smaller macular holes and you extend as far possible towards the arcades. Another technique where instead of going around, we go across the macula so that you release all the traction that is there, and that is what was being done over here. When you have these larger macular holes, what you can do is do an inverted flap technique, and instead of going all around, you do a peel 180 degrees. And after doing a peel 180 degrees, you begin again on the same end and go towards the other side. The advantage of doing this is that you can have a residual flap that you can leave as a scaffold for the macular hole to close with comparatively more ease. Excuse me. As you can see that after we have a flap remaining, you can go ahead and peel a bit more and extend it towards the arcades. That is what is being done over here. Now, I personally use ILM peeling forceps. I don't have any experience with diamond dusted scrapers. These are slightly more trickier situations when you are when you plan to do peels in patients with vitreomacular tractions. So as you can see, after doing a vitrectomy, what is being done now is shaving on the cortical vitreous around the macula. This is done so that there is a small tuft which remains while you're inducing your PVD. The chances of deroofing become less. So what was being done earlier was PVD induction at the optic nerve head, and now PVD is being induced over the macula. You can see that on the superotemporal side, we have an old branch retinal vein occlusion. That is the reason that the patient developed a vitreomacular traction. And after doing that, you complete the rest of the vitrectomy. Initiating a peel over here is again, you can use any technique. I personally like to go across the macula. It ensures that the chances of deroofing is comparatively lesser. You have to be very careful while peeling in such situations, and go slow. You don't need to be in a hurry to complete your surgery. Take a bit time and make sure that you don't end up with any complications, iatrogenic complications related to peels. And you can see that it's quite friable, and the peel. Okay, it's gone away. Oh, it's gone back. So you're completing the the ILM peel over here. Not the cases that you would want to peel all the time, but then patients who are non-responders to intravitreal anti-VEGF injections, especially when the follow-up is going to be tricky, when you have diabetic macular edema, that these are scenarios where you can peel the ILM as well. Patients with proliferative diabetic retinopathy, obviously after you clear out all the membranes and remove all sorts of traction, if it is possible, then in that situation, if the surgeon is comfortable, one can definitely peel the ILM in such situations. As you can see that the retina is comparatively more boggy over here, so one has to be very careful while peeling in such situations. One of my earlier cases when a patient with a macular hole retinal detachment. Now you can see that the retina is quite bullous over here. So in such situations, you can use a PFCL bubble, which helps in providing some amount of counter traction. You can see that the bubble over here is comparatively smaller. So I just put this case and another case over here just to show that the difference. You can use a slightly larger PFCL bubble in such situations, and then this gives you a good amount of counter traction, and you can keep extending the peel as and when you get cleavage planes. As against this, since the last couple of cases, I've stopped using PFCL bubbles in macular hole RDs. Now you can see this particular one. This was a large macular hole, and the good part in this particular case was the retina was not as bullous, and I was able to peel the ILM without the help of a PFCL bubble, and I was also able to leave inverted flap. So that the chances of hole closure are also higher with it. The important thing over here is obviously not to drain fluid from the macular hole itself and create a separate retinotomy site to drain the subretinal fluid. I'm going to skip this one because this is not related to macula. It's just an extension of an ILM peeling elsewhere. Now there are these certain situations where it's extremely difficult for the instruments to even reach the posterior pole, as this particular one was a highly myopic eye, and a finesse loop, although not the indication for kind of scraping the ILM in such situations, but then it was the only instrument that actually reached the macula. ERMPs, one can also utilize staining in such situations pretty well. It gives you a good contrast. So I'm sorry for the quality of the video over here, but it gives you a good contrast and it stains the ILM. So it's easier to peel the epiretinal membrane in such situations, and you can always stain again with the dye so that you can make sure that there's no residual epiretinal membrane, and then go ahead and peel the ILM as well. Another not very commonly done indication, but then these particular patients, this particular one for example, central retinal vein occlusion, a patient had received multiple injections, over 30 injections, classically a non-responder, and the patient was extremely frustrated with the number of injections that he had received. So you can definitely give them the option or accept their question of if any surgery is possible. So this particular patient also at least did not require further intravitreal injections. Obviously the vision improvement was not as substantial, but then what was
exploring newer skylines after unexpected surprises post-operative. I'm Dr.
Okay, that's not mine. Thank you. Yes.
One is I noticed that you don't seem to use any staining for the vitreous, which is a good thing actually, but that's something I noticed. Is that true? Or
I prefer to stain only in patients with in diabetic vitrectomies, where I feel that you have multiple layers of vitreous. There's a good amount of vitreous isis. So to ensure that all the vitreous is removed, predominantly in diabetic vitrectomies, ma'am.
Okay. Okay, that's good actually. That means your vision is very good, because generally we do need some triamcinolone to be sure that we have cleaned out. But it's good if you can manage without. You said that you leave some vitreous on the vitreomacular traction area so that the aspiration during PVD doesn't
Yes,
happen.
ma'am.
But then ultimately you do need to remove that vitreous.
Yes, ma'am. So in that situation, we try to trim it. I try to trim it as much as possible, and then just during the ILM peeling itself, some amount of cortical vitreous, it's ensured that we that it's removed. That's why I go slower when I'm peeling over the.
So basically, you're doing a 4V fovea sparing ILM
Yes, ma'am.
peeling so that you are not pulling.
Yes, ma'am. Yes, ma'am.
So that's a very good point actually. Fovea sparing ILM peeling for any situation where the foveal roof has become thin, which often becomes in vitreomacular traction, impending macular hole. In those cases, you don't want to have ILM peeling across the macula because you can deroof the macula. So that's a very important point. In bullous RDs, you said that there is a lot of, I mean, it's difficult to peel, of course, because there is a bullous. So instead of putting PFCL, you can also drain the retina first, so that you get a little flat macula, and then you can do a ILM
Yes,
peeling
ma'am.
and keep repeating the drainage if it becomes bullous.
Yes, ma'am.
So
That's a very nice point.
that's what you said. In PDR, it's my experience that while it is a very good idea to do ILM peeling to get very good visual results, the visual result is very good if you do a
Yes,
peel. But sometimes if there's a lot of traction around that area, the macula is thinned out. I've also had the experience simply trying to peel ILM, I created a retinal tear. So you have to be very careful. If you don't need to do it, don't do it. Because the risk is probably sometimes not worth it.
Very true, ma'am. In fact, most of my colleagues, especially in Europe, it was like a fad that any patient, they just any eye they would enter, they would end up peeling them. And then I was a little bit more aggressive initially, but then gradually over a period of time, I
realize it's not worth
yes,
it.
it's not worth it.
See, supposing you have a break and then you do a lot of laser there. Now you have an area in the macula close to the center where there is a scar. I have seen long term these scars develop CNVM also. So ultimately you have condemned the patient for complications in the future. Great, excellent talk. Anything else from anybody in the audience? Anybody? Okay, we'll call the next speaker. Thank you, Dr. Sen.
Thank you.
Sorry, Dr. Bansal.
Yeah, Piyush. Now, next speaker, Dr. Alok Sen. Dr. Alok Sen is there? Okay. Next is mine, Dr. BNR Subudhi. Myself. Good morning. I think the CSR is a very common clinical disease we come across in our practice. Before that, so I must thank AIO's midterm conference to give us an opportunity to speak in front of you. Thanks to the local organizing committee too. It's a wonderful conference. As I told you, CSR is a very common affection in our day-to-day practice in our country. And it has got a lot of synonyms, CSCR, CSC. So, but commonly we speak the term central serous retinopathy. It's a common retinal cause of visual loss. It's an idiopathic disorder characterized by localized serous detachment of the sensory retina at the macula, second to leakage from choriocapillaris through one or more defective RPE or outer blood retinal barrier. The main step treatment are observation, photodynamic therapy, and laser procedures. How to approach a case of CSR in your clinical practice? So first, you do a clinical evaluation. Predisposing factors are very common in these patients. They are mostly affected young males. And type A hypersensitivity, persons then steroid have taken some course of time in life, they have taken some steroids, and a lot of stressful life. That's why very, very common in young males, particularly about there are 30s, we get this disease. Symptoms, yes, the patient comes to sudden something blurred vision with a relative scotoma in the central visual field. They always complain that something black is appearing in their visual field. And sometimes they get a unilateral metamorphosia, micropsia, macropsia. So there is a drop of visual acuity in the 2 to 3 lines. This is continuous for some time. And if you do examine, there's a relative hyperometropia, you see them, and a positive photostat test in these patients. And if you do a fundoscopy, typical circular rig reflex is seen in the fundus. It's very commonly we see in our fundoscopy. And in the center of this reflex, the elevated macula, we see a small PED, white spot which is the cause of serous detachment. And of course, foveal reflex absent, and there is sometimes subretinal deposits are also seen in this area. And sometimes in the recurrent stage of chronic, you get a multifocal pigmented changes. It's a typical picture of the CSR fundoscopy. You can see whether direct or indirect ophthalmoscopy. Clinical course, yes, it resolves on its own within 3 to 6 months without any treatment, only assurance. But however, the recurrence is very common. The same, it's usually bilateral disease in one eye affected, cured, and it goes to the other eye. So chronic course sometimes lasts for more than 4 to 6 months and affects about more than 50 years, affects more than 50 years old males, and may have permanent visual impairment due to the progressive RP atrophy. Bullous, sometimes it's a large bullous CSR can be seen in the macular area. It's very commonly when following systemic steroid therapy. Differential diagnosis, there are so many things, but very common as the CSR is very typical. You can differentiate from the optical disc pit, PCV, macular hole with serous detachment, and coronal tumors. Investigation is the best common investigation we do in the OPD, the amsler degree test that detects here the early changes in the macula. Then OCT, the really diagnostic of this disease, will see a serous space in the macular, retinal layers. And sometimes you get one or more smaller RP detachments too. Sometimes you get the precipitates on the posterior surface, the detached retina and thickened choroids. Very, typical picture of CSR. FFA, yes, again, they are very typical. If you do FFA, you will see the typical ink blot pattern, small hyperfluorescent spot which gradually widens, and smokestack appear pattern, small hyperfluorescent spot which extends vertically like a smoke stack and gradually spread lateral to like an umbrella pattern or mushroom pattern. And diffuse pattern, yes, sometimes it doesn't configuration to any of these, we can get a diffuse pattern too. Aims of treatment, the aims of treatment for CSR to preserve the outer sensory retinal layers, neurosensory retinal layers, to achieve complete resolution of the serous retinal detachment and unlike subretinal fluid. It means small amount of subretinal fluid present in the subretinal space can lead to irreversible damage to the photoreceptors in the later stage. Treatment, as I told you, observation assurance in the most cases they resolve on their own. But as the patients, because the patient is usually young males, they are in their job, they find a lot of difficulty in doing the computers, everything. So they always complain they are not able to do that. Sometimes they need some treatment at that time. But those are the treatment is just like some vitamins, etc., some assurance with the cures. So the vision returns normal within 1 to 6 months. The majority of cases of acute CSR, they disappear with observation only, and some lifestyle modifications necessary. If they are taking steroids, you have to stop the steroids. So management of chronic disease is very more challenging than and may include either the medication or laser-based treatments. So sometimes give the medical treatment like mineral corticoid receptor antagonist, epirolone, spironolactone, 25 milligram per day for a week, followed by the 50 milligram per day for 3 months. Rifampicin long time back, sometimes the tuberculosis is imposed on this CSR as the cause, and we have seen after giving rifampicin course of 5 to 6 months, it resolves very nicely. So now we can also recommend 300 milligram twice daily for 3 months. Estazolamide, yes, sometimes it reduces the macular fluid collection, so 250 milligram per day in divided doses can be given to reduce the side effects. Melatonin, propranolol low aspirin can be tried in these cases to give some relief to the disease. But again, anti-VEGF treatment is again controversial. Yes, whether you would like to give anti-VEGF in these cases or not, but sometimes we give anti-VEGF as a part of some other treatment to see that there is a complete resolution of the disease. So reduce the vascular leakage of the tight junctions of the endothelium, reducing the leakage from the choriocapillaries to the subretinal space. Thus it cures the disease, so anti-VEGF can be tried. Lasers, yes, if the patient comes with a recurrent CSR or a long course of CSR, you can try a focal laser. Sometimes we call it focal fomentation. We call it focal fomentation. Just a light laser can be given to the area so that at least you can reduce the leakage and keeps tightens the junction with the endothelium cells. Indication, long-standing cases, more than 3 months, patient with recurrent CSR with vision loss, and patient having permanent vision loss in the other eye due to this condition. So, but only contraindication, leak within a FAZ zone. That will damage the macula, get permanent damage. Subthreshold micropulse laser is another again the modern treatment. So use of micropulse diode laser can induce more subtle effect due to in the outer retina compared to the laser protocols. This appropriate micropulse laser treatment can selectively target the RPE while preserving the photoreceptors without causing visible tissue damage. PDT, yes, PDT can be tried within just 1 minute. So may be beneficial for those with severe disease not able to conventional laser treatment, but PDT is again still a costly instrument. Not many centers are doing PDT, so PDT is stopped in many centers. So it's a very limited offer for the treatment. CSR AI, the application of deep machine learning and AI for patients with recurrent CSR can predict recurrence factor identification and precise individual interventions which will help and reduce the vision loss caused by the CSR recurrence. So AI is, it has got its CSR too. So to conclude, this is a very common disease we come across in day-to-day practice. Every day we may come across one case. So although the pathologies are still incompletely understood, but the advances in the imaging techniques and the management methods and the continuous study of CSR will guide the treatment to an increasingly confident and promising direction, and we get now the CSR is reduced and the patients are very happy with our treatment. So thank you very much for patient listening. I request to give me your valuable vote for the editor proceedings which I am contesting for in the elections 2023. Thank you very much.
Thank you, Dr. Subudhi. That was a nice overall view of CSR.
Yeah.
One of the things which you mentioned is steroid. Of course,
Yeah.
we always take that history. Another important thing is sildenafil in males, Viagra.
Yeah.
I have males who later on say that they have been taking, and that's when they come back with recurrences. But they did not reveal it earlier. So it's
Yeah.
our duty to ask.
But many times you don't take, as you said, we don't ask that
Yeah.
take a sildenafil.
You have to ask now. Just like we ask
Because
steroids.
this disease is mostly common in young males, so we don't expect that he must be taking sildenafil. Sildenafil is given the latest age group.
Yeah, but you have to ask.
Yeah.
I've had males in their 40s who were taking it.
Yeah.
Also, we have lately seen CSR in females because they were on steroids for COVID management. So suddenly there was a flood of CSRs in females also. An important feature of CSR can be gravitational tracts. So sometimes when CSR can look like AMD because of the fluid collection in the elderly, it can look like the chronic CSR which you mentioned.
Yeah.
That looks almost like AMD because of RP detachments as well as sometimes associated with CNVM as well, intraretinal fluid, subretinal fluid. So one of the ways to make out whether it's AMD or CSR is a gravitational tract which goes down.
That's why this anti-VEGF treatment has come.
Yes, yes.
Because it's associated with AMD, so the anti-VEGF works in these patients.
Yes, correct. But it works very well for AMD patients,
Yeah.
anti-VEGF, but it doesn't work that well for CSR.
CSR,
so
right.
if you have an idea that it is CSR, you will prefer to go for PDT or other options.
Absurd.
It's very important to make out that this is also not choroiditis or scleritis because there the treatment is opposite. You give steroids, whereas in CSR, if you give steroid, it will make the CSR worse. So it's very, sometimes it's confusing whether it is a choroiditis, scleritis, leukemia which is presenting with a macular detachment, disc pit maculopathy and CSR. So differential diagnosis is extremely important because in many of the diseases you want to give steroids, but CSR that would be contraindicated.
Yes.
I've seen cases where intravitreal injection of steroid has been given thinking that it is a cystoid macular edema or some such disease. Or it's a vitreitis associated with CME and they've given a steroid. And the CSR becomes bullous actually. So it's very, very important to have the correct diagnosis. Anything else, Dr. Bali, you would like to add?
Just one observation, ma'am, regarding
Please,
steroid
please.
intake. That many times the patients are on some alternative medicine treatment, and they themselves they don't know whether they have been they are being given steroid or not. So that history is also important.
Ayurvedic medicines, they are also very big culprits. So that history also should
Absolutely
be
correct.
definitely taken.
Yes.
But anybody doing PDT, madam? Anywhere PDT?
PDT last 2 years the Visudyne is not available in the country. But otherwise I used to do a lot of PDT.
Lot of PDT, yeah.
And what
But
we
for
used-
CSR?
CSR only.
Achha.
And actually in CSR, those patients who used to have frequent recurrences over the years, they would never have a recurrence after PDT because PDT actually causes choroidal remodeling. The hypervascularity, hyperpermeability reduces permanently. It reduces the size of the vessels. So it's a permanent treatment actually. It's ideal for CSR actually.
Good.
But it's not available.
Not available, okay. Thank you, ma'am.
Thank you so much. Very
Thank
good
you, thank you.
review. The next speaker is Dr. Shivendra Sahai, newer developments in anti-VEGF medication.
Chairman, Madam, dignitaries, on and off the dais, very good morning to you all. Today I am here to discuss new developments in anti-VEGF medications. I have no financial disclosures to make. You all know anti-VEGF injections which dominated up to 2020 were ranibizumab biosimilars, then bevacizumab biosimilars, pegaptinib, Macugen, which is now no more in use, then aflibercept, which is marketed as Eylea. It was FDA approved in 2014. Just for sake of revision purpose, aflibercept is a fusion protein that binds VEGF-A with higher affinity than bevacizumab and ranibizumab, and also binds VEGF-B. Because of its dual domain arm, it provides double VEGF trap, and that is why it is more potent. Now, aflibercept is marketed as Jaltrap, has the same therapeutic use as that of Eylea. It is shared injection, available in bigger vials like Avastin. It is off-label drug mainly used in colorectal carcinoma, but there are issues related to dose and osmolarity. It is not FDA approved and it is not commonly used in many centers. Now, new developments occurring after 2020, new drug arrivals, brolucizumab, faricimab, conbercept, and new delivery system, port delivery system, pre-filled syringes, 34 gauge needle, etc. Now, you all know about the Pagenex. It is a Novartis product, brolucizumab. It is humanized single chain antibody, inhibits all isoforms of VEGF-A. It is the smallest functional unit of an antibody. And among all anti-VEGF, it has the lowest molecular weight and greatest molar dose. So it is more it has more tissue effective tissue penetration, and that is why it reaches choroid very easily. As I've earlier told, it has the smallest molecular weight. The molecular weight of brolucizumab is only 26 kilodalton, whereas bevacizumab is 149 kilodalton, and aflibercept 115 kilodalton. So small molecular weight, high molar dose plus high drug concentration make it more effective. It is 11 times more effective than aflibercept and 22 times more effective than ranibizumab. Now, if you give one shot of aflibercept, its equivalent molar dose is 1, and if you give one shot of brolucizumab, equivalent dose is 11.2. So, brolucizumab is 11 times more potent than brolucizumab. Now, since it is a talk of only 7 minutes, I will be discussing all these studies in very short. Hawk and Harrier are two similarly designed phase 3 trials which were comparative study between aflibercept and brolucizumab, comparing their safety and efficacy for treating neovascular AMD at different dose intervals. Hawk was performed in American continents, then Japan and Australia. Harrier was performed in Europe, Asia and Southeast Asia. Now, Hawk study, Vibhuti, Dr. Vibhuti, can you come here? Yeah, sure. Anyhow, CNVM Hawk study was performed with 3 milligram as well as 6 milligram dose, and in that study CNVM as well as PCV was included, and in this Harrier study only CNVM was considered. Now, observation of Hawk and Harrier in simple words, after loading dose of 3 monthly, that is 4 weekly interval, brolucizumab when given at 12 weekly interval, that is 3 monthly interval, and aflibercept when given at 8 weekly interval, that is 2 monthly intervals, you can say, brolucizumab gave a similar and non-inferior result compared to aflibercept. So, summary of vision related outcome, they considered 2 points, 48 weeks and 96 weeks. They found that brolucizumab was non-inferior to aflibercept for the mean change in BCVA at 48 weeks, and which was maintained up to 96 weeks also. Then safety concerns with brolucizumab, in both the Hawk and Harrier, both studies, they found that brolucizumab was producing intraocular inflammation, which was not there with aflibercept. Now, some Indian studies, Braille study is very important. Debdudal et al. Did a Braille study. It is a 52-week PRN study done in naive or switch therapy Indian patients of neovascular AMD. And this study, in simple words, injections were given on SOS basis, considering the situation of visual acuity and OCT anatomical findings like SRF, intraretinal fluid, central macular thickness, PED. And it suggests that unlike monthly loading dose or 3 monthly maintenance dose as suggested in Harrier and Hawk, we can give brolucizumab injection as per need on SOS basis, hence reducing the burden of injection, helping much to the Indian poor population. Now, this is the dose duration between first and second, 10.98 week. They suggest that could yeah. Then duration between second and third, 11.71 they suggested. So, in this way we can reduce the burden of injection. Now, coming to the Kestrel and Kite studies, these were two different studies, and they were the purpose of this study was to compare the efficacy and safety of brolucizumab with aflibercept in patients with diabetic macular edema. Now, in Kite study, Indian patients were also observed. The results were that after a loading dose of 5 injection, here they gave a loading dose of 5 injection. In Hawk and Harrier, they gave a loading dose of 3 injection. The patients maintained a stable vision with 12 weekly brolucizumab injection compared to 8 weekly aflibercept injection. This is the elaboration of results of Kestrel and Kite. And then coming to faricimab, it is a bispecific antibody that binds and inhibits both VEGF A and angiopoietin 2. It is not available in India. It was FDA approved in 2022, and certain trials have been done in this case. Tania and Lucinta trial was done. It is a comparative study of faricimab with aflibercept for treating neovascular AMD, and they observed that faricimab is non-inferior to aflibercept in terms of BCVA in treating neovascular AMD. Now, there is a new molecule, conbercept. It is commonly used in China. It is a heavy molecule, 143 kilodalton, and it is a strong drug. It binds all isoforms of VEGF A, B, C, but it has certain issues related to complications. That is why it is yet to be FDA approved, and it is not used outside China. Then abicipar pegol is a new molecule which is in pipeline. Now, new developments in delivery system. Lucentis PDS was launched. It is not available in India. It is surgically implanted refillable device, allowing continuous delivery of specially formulated ranibizumab. Here you can see what happened. Cursor is not moving. Yeah, here you can see the drug is continuously being released in the vitreous cavity, and a study was done, ladder study, which showed that we could refill this refillable device every 6 months. Then this is how it is refilled, and this is the slide. These are the slides showing how it is implanted. Phase 3 trial was perhaps done in Shankar Nethralaya, and these slides are how to implant. These are the slides from Shankar Nethralaya as the people have supplied to me. Now, coming to the another depot formulation. Now, pre-filled syringes, Eccentrics have come up with pre-filled syringes which is available in India, you all know. And now less traumatizing needles have arrived for intravitreal injections, 32 gauge, 33 gauge, 34 gauge needle. Thanks for your patient hearing.
Very good overview, Doctor. Just a few points about brolucizumab. One thing very important to mention is the risk of inflammation, because while it is definitely more effective in drying effect than aflibercept, the risk is of inflammation, almost 1% risk, of which some percentage will even have neovascular glaucoma. So that is the thing. The port delivery system allows injections every 6 to 8 months, but that has been recalled in the US because there is some defect in the septum.
The device was leaking as the report.
Yeah, some problem has happened, so that has been, currently it is stopped being used. But otherwise, that was a very good option, 6 to 8 monthly refills. And then there is now the gene therapy, which is not, of course, not anti-VEGF, but it's the gene therapy which has shown very good promise in AMD, but not for DME. In DME, they had to stop the trials, the Infinity trial, because of the hypotony that was happening. But for AMD, it's a single intravitreal injection, and practically for life, it may give you freedom from treatment.
Right.
So, faricimab is, of course, something very good that we are looking forward. India is going to have it this year.
Yeah.
We are looking forward
Yet
to
it has not arrived in India.
It has arrived in India?
Yeah, no, yet not arrived.
Yeah. It's definitely something we are looking forward to, but as of now, we are quite happy with the results with aflibercept as well, where we are getting, yesterday I had shown Q16, Q24, Q32 results also.
Yeah.
Anything, Dr. Bali or Dr. Sinha? Dr. Tinku?
I want one question.
Pardon?
The brolucizumab and that's better than Avastin?
Definitely.
See, they are definitely different group of drugs. The aflibercept binds its binding affinities and it is more powerful because of the VEGF trap. They are more potent than the
cost factor is
ranibizumab.
concerned. I'm asking for the cost point of view.
Cost. It is a shared injection, that's why it will be cheaper, but there are issues related to Avastin, you all know.
Once you make it in series form and some at a time it will 3-4 patients or 5 patients you give,
Yeah.
it's quite economical.
Yeah, it's definitely economical. No, nobody can deny that.
Agents, I think brolucizumab has the greatest drying effect, especially in patients who have not been responding to other injections. I think
Yeah.
it works like a charm.
It works, definitely, but patient has to be informed of the risk of inflammation. That has to be informed.
Yeah, that has to be informed, but practically the inflammation, very few patients, very little inflammation. I mean, personally, I have not really.
Yeah, you may not have had personally, but there are a lot of incidents.
I also tried one patient of post-surgical CME.
Yeah.
Company
I think-
people told that I tried everything.
Okay, then it's fine.
Then I thought, कि अच्छा तुम बोलते हो तो चलो, give me one sample
Yes.
and I'll try.
Yeah, it works, definitely.
It worked in that also.
It
So it is, I can say that
problem is only the
we can
inflammation.
keep it as reserved drug. We cannot start outrightly. No.
In fact, Kestrel and Kite study with DME, which you mentioned, they had to stop the recruitment for brolucizumab.
No, our venous occlusion study, it was done. That had been abandoned.
Abandoned, okay.
Kestrel and Kite, they are continuing with that.
Okay,
There is
thank
no
you.
wow effect, what you see in the diabetic macular.
Thank you, Dr.
But-
Sahai. I think it's a nice discussion following this your talk. And I request now Dr. Malika Goyal to present her talk on retinal vein occlusion, what we were discussing just now. So, yeah. And, Dr. Himadri Chaudhary has come. And Dr. Satyaprakash Tiwari? Yes. You are there. Okay, then last talk. Just sit down. Let her finish. Okay, please. And not now.
So I'll be speaking on retinal vein occlusions, mostly my own experiences. The audiovisual team has been extremely poor, and we still get the same problem throughout the conference. Okay, so retinal vein occlusions, it's the major risk factors are known: hypertension, diabetes, dyslipidemia, and tobacco use, but also sometimes coagulopathies, homocystinemia. Now, a local risk factor in the eye which we can often miss is glaucoma. So look carefully in every patient of RVO for glaucoma, because these are the common coexisting problems. And if there is glaucoma, then we should try to avoid steroid injections for the macular edema in RVO, because the risk of IOP rise. Similarly, when we treat glaucoma in RVO, we can try to avoid the prostaglandin analogues and the alpha agonists, because they would increase the risk of macular edema caused by RVO. So index of suspicion needs to be very high. The RVO can be central retinal vein occlusion, hemiretinal. Each of these can be ischemic or non-ischemic, and the non-ischemic can convert to ischemic. And branch vein occlusion, which can be a major vein or a macular vein occlusion. So we know the complications most commonly is macular problems, but in BRVO we can have new vessels on the iris or disc, and in the patient of HRVO or CRVO, the biggest bugbear is neovascular glaucoma, which starts as iris new vessels and angle new vessels, which we should be able to pick up early before it goes into the glaucoma stage. The risk increases when we stop anti-VEGF injections for management of glaucoma. Then in the second or third or fourth year, they can come back with neovascular glaucoma. So this is very important. And a non-ischemic case does not mean that lifelong it will be non-ischemic. We have to be very careful. Investigations include, we know, OCT and angiography, but also fundus photography is very important because it documents certain things like retinal hemorrhages, new vessels, or hard exudates, which are not documented by OCT. Such as this patient, within a month, within 3 weeks, you can see the hard exudate moving into the foveal center, whereas the OCT is normal. So if you didn't have a fundus photograph, you won't document this progression. Similarly, OCT is showing that macular edema is reducing on treatment, but you see that the hard exudates are increasing. So you need to step up the game and do something different. So photographs are important. Similarly, this patient treated over 5 years, it looks on the OCT as if there has been no change, but if you see the photographs, hard exudates have resolved because of treatment. Fluorescein angiography, of course, is important for new vessels, non-perfusion, but these things can also be nowadays seen on OCT angiography without intervention. So what is the USP of fluorescein angiography in vein occlusion is, it shows leakage in a branch vein occlusion, which can allow you to target your laser. And also in a patient with hazy media, new vessels can be shown up on angiogram, which are not clinically seen, and sometimes you can actually pick up new vessels on the iris, which you had completely missed on clinical examination. Now, OCTA can also nowadays show us the new vessels, non-perfusion, and the FAZ enlargement, etc., but it cannot show us the leak for laser. Treatment of macular edema is anti-VEGF or sometimes steroids injections. Some studies to show bevacizumab versus aflibercept. This is a SCORE 2 trial which showed that complete resolution of macular edema can happen in the aflibercept group, 2 times more likely than in the bevacizumab group. And those who do not respond to bevacizumab would respond to aflibercept. Also showing the treatment burden can be reduced with aflibercept, fewer injections are required, and greater proportion of patients would have a thinner macula with aflibercept compared to ranibizumab. The Newton study, where it was done with patients where the recurrences were happening within 4 weeks, and the ranibizumab was required to be injected every 4 weeks, ranibizumab or Avastin. They were shifted to aflibercept, and the treatment interval could be prolonged by 26 days, so it became double, from 1 month to over 2 months, with further improvement in vision and decreased retinal thickness. So showing that aflibercept reduces the treatment burden, is more effective, and just overall gives better result. Steroid indications are less than anti-VEGF, but wherever anti-VEGF cannot be given, systemic contraindications like recent strokes or heart problems, pregnancy is a contraindication for anti-VEGFs, nephropathy is a relative contraindication, or when there is traction has started in a proliferative case, there you would not like to give anti-VEGF, it could cause a retractional detachment. In those situations, or where you have tried anti-VEGFs and failed. Also when you are planning cataract surgery, because there steroid can give an additional anti-inflammatory effect. But steroid or DEX implant should not be used when the posterior capsule is missing, or there is a large rent, or there is a scleral fixated IOL, because it can migrate into the anterior chamber and cause an emergency. Also in immunosuppressed patients, it can trigger infection like a local CMV retinitis or even ARN. Macular laser is indicated in branch vein occlusions. It can give long-term response, as was found in the BVO study long back. It's a long-term benefit, not an immediate benefit, but not for CRVO. There is no role in CRVO or HRVO. However, scatter laser is of course required whenever there is new vessels, whether it's BRVO or if it is CRVO. In CRVO, if you see angle or iris new vessels, PRP. Follow-up, very important, is to look every visit in CRVO and HRVO especially for new vessels on iris. Do a gonioscopy every 6 months at least, and look carefully for NVD, NVE in every case of RVO, and very important, look at the fellow eye. Fellow eye may be having asymptomatic vein occlusion which will lead to proliferative retinopathy. Be very highly suspicious. This was a patient looking very bad with some hemorrhage. Though there was no new vessels. I still did scatter and anti-VEGF. Despite that, at 2 months he was bad. Again added and some laser. Despite that, he went into neovascular glaucoma. This is CRVO with a cilioretinal artery occlusion, a common association. Bilateral often, these are cases where the other eye is asymptomatic. And in the young, the left side shows the cause for idiopathic mostly, but can be tuberculosis, syphilis, HIV, or any autoimmune diseases. Blood dyscrasias, oral contraceptive pills, sildenafil, and now post-COVID, we are seeing in post-COVID vaccine many patients. Generally, the prognosis is much better, steroids, oral, or even sometimes anti-VEGF. This is post-COVID infection, CRVO, and this is a post-vaccine CRVO. On the left side, you see CRVO with IT-BRAO, and on the right side, you are seeing a superior hemiretinal vein occlusion within days of vaccination. And in all these cases, post-infection or vaccine, we give oral steroids, anticoagulants, and if required, anti-VEGF. Thank you.
Any comments from the audience? So I think we are seeing commonly both the cases with CRB or BRB very commonly seen in our day-to-day practice.
Yeah.
Am I right?
Yeah, of course.
So when do you advise to give the injections, intravitreal injections?
When do we advise?
Yeah.
See, the fact that they have come to a doctor, it means they have macular edema already. Otherwise, they would not know it.
Yeah.
So macular, once they are symptomatic, it's anti-VEGF injections is the drug of first choice. Very rarely you would move to steroid as the drug of first choice because of the complication of IOP rise, and if they are phakic, then you don't want to create a cataract. So
sometimes a lot of hemorrhages are there in the macula and even the retina. Would you like to wait for some time till the hemorrhage disappears, or you start giving the injections right?
No, hemorrhages has no bearing with the injections. We can give it because we want, because it has been shown in all these studies, randomized studies, that time is important. When we delay the treatment even by a few months, we don't get the same vision after starting injections than if you start immediately.
So irrespective of hemorrhages, you can start.
Yeah, absolutely, absolutely. Hemorrhages were previously considered a contraindication because FFA was not allowing good view, and so laser was not possible. But for laser, hemorrhages are a contraindication, but not for anti-VEGF.
For injection. So you can give 2-3 injections.
Should give immediately. The earlier the better.
It's very good.
After investigating, of course.
Yeah, of course, true.
Yes, Dr. Bali.
Okay.
It's very important to emphasize to the patient also the risk of a delayed vitreous hemorrhage from neovascularization. So many times when the edema subsides, the patient is lost to follow-up and then comes back 2-3 years down the line with a vitreous hemorrhage. So it's very important that we educate the patient that this could be a late sequelae of.
Absolutely. Any BRVO which is asymptomatic also, we have to tell them that this can cause blindness later on. So every year review is important.
So immediately after diagnosing the disease, do investigation and start giving the anti-VEGF treatment. Right?
Yeah, and then tell them that even if you don't take injections, no problem. Macular edema will not cause blindness, but at least come back every year to look for proliferative retinopathy.
Thank you very much for the good discussion and good presentation. So now I think last talk will be Satyaprakash Tiwari. So please go. I'm moving. I've got another session to go.
What is your reception?
No, I have to go one more session. 12:30. Thank you very much. Nice to see you. We enjoyed.
Your WhatsApp,
Yes, sir. Good morning, all of you. I am going to present Pulse of Macular Surgery, a video-based presentation. Nowadays, the MIVS surgery has improved a lot, and from 20 gauge to 23 gauge, 25 gauge, and now we have come into the era of 27 gauge. 27 gauge surgery is ideally suited for macular surgery as there is less manipulations in the peripheral part, because 27 gauge instruments are little bit fragile and we cannot manipulate the globe as vigorously as it is possible in 25 gauge and 23 gauge study instruments. But anyway, we have to make working port little apart so that it helps us in manipulating the globe without much strength. After just inducing PVD and doing vitrectomy, core vitrectomy, removal of peripheral residual vitreous, we can stain the internal limiting membrane and we can just start peeling with a pinch and peel technique. 27 gauge forceps are available. which are very good, and that tip of the forceps are very suited to grasp the ILM properly, so we can lift the ILM at one place by pinch and peel, and then we can continue our peeling, and we can extend the peeling all around up to the arcade, so that we get a good closure, and all small macular hole can easily be closed by just doing a vitrectomy proper and ILM peeling. Of course, large macular hole and chronic macular hole needs a special technique of doing inverted ILM flap technique. So another case of removing ILM in case of a chronic branch vein occlusion, the patient received multiple intravitreal injections and a sector laser PRP also for neovascularization. There were a lot of hard exudate around the macula as well. In these cases, the ILM and ERM are very fragile, and we will get patchy peeling. We cannot get continuous capsular axis kind of peeling, and we may need to stain again and again to improve the visualization. After removing a part of ILM, if we are not getting the edge, or we are not comfortable in seeing the contrast of the peeled and unpeeled area, then we can go again and stain. We can do double staining with trypan blue and brilliant blue as well, or if we can use ICG as well. So by doing that, ILM can be removed in such cases. This is again a case of idiopathic epiretinal membrane. Such cases are not very difficult to peel, because once we get an edge of that ERM, generally it comes in a sheet, and so that we can peel. But many a times tough membranes definitely need multiple patchy peeling, and then we can, or if we get an edge of ILM, sometime it can come along with ILM also, so we can remove ILM and ERM in one go. So these cases also fare better if we go with a micro incision vitrectomy system. This case, this is again a case of, I think, this is just a simple macular hole. This is a little bit large macular hole. So we decided to do inverted ILM flap technique. So doing inverted ILM flap technique, there are many techniques available, in which some people do cabbage technique, like peeling all around and leaving a small patches of ILM and then putting inside the hole. We generally prefer that we peel all around, leave a small tag of ILM in the temporal part, and do not try to push that tag inside the hole. Just do fluid air exchange with a wave of fluid air exchange being done at the optic nerve head. That flap, temporal flap, comes and covers the ILM, covers the macular hole, and this gives excellent result. Even with larger holes, we have closed with just fluid air exchange and air, no gases, or at least just with SF6. We very rarely use C3F8, and this just temporal only inverted ILM flap technique works very excellently, and visual recovery is also a little bit better as compared to just pulling the ILM all around and stuffing it inside the macular hole. This is another case of, this is a failed retinal detachment surgery. That vitrectomy was done for retinal detachment, and there was a redetachment. So there were membranes over the macula also, a thin PVR membrane. So we decided to just put PFCL, stain the ILM, and remove all the proliferative tissue along with the internal limiting membrane, and then drain through another retinotomy and just put silicone oil. And we generally get good outcome, as removing ILM over a large area gives relatively relaxing retinotomy kind of effect in these failed retinal detachment cases. This was a failed macular hole surgery operated elsewhere, and the patient came for a second surgery, and since vitrectomy was complete at the earlier setup, so we just stained the ILM, and we found that there were a lot of ILM tissues left, and that was the probable cause of non-closure of the hole. But that helped us in doing this surgery, because suppose the ILM is completely removed and then the hole doesn't close, then it becomes a little bit challenging case. We have to retrieve ILM from somewhere else, and we can do free flap, or we can do retinal autograft, or amniotic membrane graft, or capsular graft, whatever. But in this case, there were a lot of ILM left in and around the hole, so we just removed all those ILM carefully, and we took just a free flap, put over the hole, and then we covered that free flap with the that adjoining ILM which were present around the macular hole edges, and that gave excellent outcome. The patient had in earlier surgery the patient received C3 effect, but still the hole didn't close because the ILM was not properly removed. We did a resurgery and we just give SF6 and the hole was closed within a week. This is another case of macular hole surgery, not macular hole, this is a subretinal PFCL. This was a foreign body with giant retinal tear operated by myself, and view was poor and PFCL went behind, and the retina was absolutely attached, but we found that the fovea is having a large bubble of PFCL in the subretinal space. So we took 39 gauge cannula topped over 25 gauge system, and we just pierced the retina adjacent to fovea, and we took out that PFCL bubble carefully, and we corrected this situation by doing just this removal of subfoveal PFCL. This is another case of failed retinal detachment surgery. There are epiretinal membrane over the retina and subretinal fibrous band developed behind the retina. It was a traumatic retinal detachment which was operated, but unfortunately didn't close, and there were a lot of proliferative changes over and behind the retina. So just did a retinotomy to remove the subretinal band. It was just grasped with a forceps, and we took out that subretinal membrane, and then put PFCL and stain the ILM and ERM over the macula and remove those ILM and ERM. So that way we took care of these proliferative tissues behind the retina as well as over the retina, and that gave excellent outcome. Closing the retina and putting silicone oil led to attached retina. So these were some of the cases in which how we can tackle the macular pathologies in modern era of microvitrectomy system, and by that way we can get good outcome in modern days surgical system. Thank you so much for the patient.
Excellent, very good videos, doctor. Would you, for the benefit of myself and audience, say what is the sequence under PFCL when you're doing an ILM peeling? The sequence of injection of dyes, would you first put the dye, then put the PFCL?
No ma'am, in Arvind we have been trained by just put PFCL and put a small amount of dye in the PFCL bubble, and it goes behind that PFCL bubble and stains brilliantly. It has been shown and presented by Dr. Naresh Babu in many conferences also. So we have been trained like that, just put PFCL and stain under it with the dye. That saves time also, and we frequent changes of instrument also. So it stains well ma'am.
Put a few drops of...
Yes ma'am, and once this is very good, like if we can go with a soft tip injector, and if we go in the interface of PFCL and retina, even if you inject one drop, it stains like just like a thin layer over the ILM, and staining is very good under PFCL.
So you don't inject in the bubble of PFCL, you go under the bubble?
Yeah, mostly if you go under the bubble, that stains very brilliantly.
If you inject inside the bubble, what will happen?
Sometimes some small amount can go behind the bubble and stain, and majority can come out in the vitreous cavity, and it doesn't have any staining effect over the ILM.
Very good. And what is your experience with managing membranes with oil in situ?
Managing membranes under oil is a bit challenging, but it is good also. Sometimes without removing oil also we have gone inside, and suppose the membrane is mature and comes in toto in a single set. Many times we have done like just go, if there is a single membrane, just remove that membrane, and if there is small subretinal fluid, we can just do a limited FAE near that by doing a retinotomy, and then we can top up some silicone oil and doing laser, and so that avoids removing silicone oil. But if we see large area of membrane and large peeling, ultimately we have to remove silicone oil. But whenever we are doing under silicone oil surgery, we just first go inside and see whatever we can remove under oil, and then if needed remove the silicone oil and look for the residual membrane, and then those membrane can be removed under PFCL by staining, and then we can remove that.
Exactly.
Yeah.
When you see a membrane post, let us say an RD surgery, RD surgery has been done many times, so we do expect membrane.
Yes.
If you see a membrane, do you operate immediately? Do you think that we should remove early, Or do you think you want to wait for it to mature so that it's easier to remove thicker? Do you give some steroid injections to make it more stable before you intervene under the oil?
Ma'am, if the eye is under oil, I generally do not hurry. I generally wait. If it is not, the macula is not bullously detached or something like that, if it is a peripheral detachment, I do explain to the patient that you are developing some membrane and you will need another surgery, but we will wait. We will wait for the maturation of membranes and then we can go inside. If it is bullously detached, or sometimes what happens, there is a PVR, there is detachment and the brakes also opens up, and in those cases sometimes silicone oil also goes behind the retina, then in those cases we have to operate early.
So what I also do, as you said, if there is a membrane under oil and the retina is otherwise good, stable, I personally feel that it's better to wait. I sometimes, if it's increasing and the traction is little bit increasing, I prefer to give us a periocular steroid injection, couple of injections, which prevents too much of contraction and too much of fibrosis and scarring. And then when I feel that it has stabilized, it is thick enough to come off easily, is when I do intervene, and I have found very good results.
Yes, ma'am, exactly. That is very good technique, because under oil we are not in a hurry. If it is under gas, then we know that we have to operate early, but under oil we are safe. We can wait for a few days.
Excellent, excellent.
Thank you so much, ma'am. Thank you.
Anything, Dr. Bali, anything? Tinku?
So one thing is that, like you said, you put PFCL in RD cases, RD with macular hole. In case you not put PFCL, be very careful while injecting the dye, because sometimes you can do subretinal.
Yes, ma'am.
So very gently you have to hit it.
Definitely, ma'am, definitely.
And in most,
In the PVR cases, the RD cases of PVR, it's always a good idea to do IOL reading at the macula, because these cases generally will land up as PRNs. So these are the cases in which I always like to combine an IOL reading. And sometimes even near the break, if you have like eroded edges, or even near the break, you can do IOL reading. So that also helps.
yeah.
Yes, ma'am. Very valid points, ma'am. Thank you.
And when you're doing a large macular hole, it's always better to have autologous serum ready. It takes nothing. The anesthetists know how to do it. They just centrifuge the blood and keep it. So you can always use that as an adjunct in your large holes. Just put some drops and it helps closure. Especially if your flaps have, sometimes I plan inverted flap, but the flap somehow goes off. Then you at least have something to put in the hole.
Once I put in just one of my operated case, patient just didn't come even for day one follow-up. One eye was operated, macular hole, excellent result, 6/9 vision. The other eye, macular hole operated. After surgery, patient went back home, removed the patch by themselves, and just came after 1 month of the surgery. Didn't maintain position, the hole definitely failed, and lot of peripheral PVR. So resurgery was done. My colleague was doing surgery, so he removed all the membranes and all. Retina was not detached, but there was nothing to put. So he called me, what should we put? And I did already cataract surgery, so there was no capsule. So we just tried to remove, and after removing that PVR, there was small membrane kind of thing around that PVR. So I just took that membrane and put over the hole, and fortunately that patient also that had closed hole. But in that case, since lot of peripheral PVR were there, we put silicone oil in that case rather than putting for the gas. So we can take something somewhere from the retina and we can close failed hole also.
The worry with the membrane is it could cause some scarring because it's a fibrous tissue.
Yeah, but in that case we didn't have anything, so we tried that and we succeeded.
Very good. Thank you very much. Can we take a photograph, or your session is late?